Welcome everyone to the University of Ottawa Nephrology Grand Rounds. It's my pleasure to introduce our speaker here, Dr. Heerspink, who is speaking today from Groningen. And we're quite honored and privileged to have him speak, as he's in very high demand for this topic that's of great interest to us all in nephrology. So just a reminder, please, everyone, mute your lines so we can hear Dr. Heerspink clearly. And now I'm just going to hand things over to Dr. Heerspink, who's going to give a more formal introduction of our speaker this morning.
Thanks, Greg, and welcome again. We are delighted to have Professor Heerspink talk about Flozination, about SGLT2 inhibitors, extending the use from diabetes to non-diabetes. Professor Heerspink is he's a professor of clinical trials and pharmacology at Groningen in Netherlands. His research interests focus on optimizing current treatment strategies for renal and cardiovascular diseases. He's extremely well funded and he's extremely well published with over 400 peer-reviewed publications and more than 50 papers this year itself. So without further ado, I will let Dr. Heerspink present. We would like to, of course, thank AstraZeneca for their support to make this possible. If people have questions, feel free to put them in the chat box, but we will come to questions and answers at the end. In addition to that, just note that this presentation is being recorded and will be made available to others for sharing subsequently. Professor Heerspink.
Thank you so much for the introduction and the invitation to be with you this morning. Although at a distance, I would have loved to physically visit your hospital and present, but hopefully we can do that in 2021. I'm going to talk about, as you say, SGLT2 inhibitor Heerspink, and I will review recent studies with a focus on the kidneys. We'll talk a little bit about heart failure, and in particular, we'll focus on the effects of SGLT2 inhibitors in patients with without diabetes. Let's see if this slide advances. Yeah, my disclosures are listed here. So we all know that the number of patients who are estimated to receive kidney replacement therapy will increase in the coming decade. And this is a study on the left that has been performed a couple of years ago, where the authors tried to estimate how many patients will need kidney replacement therapy around the world. And what you can see from this slide is that in particular in Asia and North America, the numbers are expected to increase. What we've also seen, and which was published this year, is that the number of patients who die from chronic kidney disease have increased from 2007 to 2017. And although this increase may not seem a lot, 1%, if you compare this to other chronic diseases, we see that in these other chronic diseases, the number of patients who die from these diseases have decreased. So these data together suggest and highlight the need for new treatments for chronic kidney disease in order to reduce the number of patients who need kidney replacement therapy and to reduce mortality in this population. And of course, we haven't been quiet. People have tried a lot and tried to identify and to develop new drugs over the last 20 years. And the focus has been predominantly on patients with type 2 diabetes and kidney disease, as indicated by the light blue bars in this graph. If you look at patients without diabetes or patients with type 1 diabetes, the numbers of clinical trials are limited. Actually, there are only 5 clinical trials in patients without diabetes, and these trials were generally small. Thus, they do not allow to detect small yet clinically meaningful treatment effects. What have we learned from the past clinical trials? Of course, at the end of the 90s and in the early 2000s, the ACE inhibitors and angiotensin receptor blockers came to the market, and they were shown to be protective in patients predominantly with diabetic kidney disease, although some of the trials were also done in patients without diabetes and kidney disease, as you can see at the bottom of this cartoon. But then there was 20 years lack of innovation until last year, when at the same time the Credence trial and the SONAR trial were presented at the International Society of Nephrology meeting in Melbourne. And both these trials demonstrated that an endothelin receptor antagonist in the SONAR trial and an SGLT2 inhibitor in the Credence trial protected the kidney to quite some extent, 35% relative risk reduction for kidney failure in the SONA trial and 34% relative risk reduction in the Credence trial. And then this year we saw the results of the DAPA-CKD trial that also showed that an SGLT2 inhibitor is effective in patients with chronic kidney disease, both with and without diabetes. And we will look at the data in more detail today. Last month, we heard the results of the Fidelio DKD trial, which was a clinical trial in diabetic kidney disease that demonstrated that a mineralocorticoid receptor antagonist reduced the risk of kidney failure as well. So suddenly times is going to change, and after 20 years of stagnation, we suddenly have a couple of drugs that can protect the kidney on top of ACE inhibitors or angiotensin receptor blockers, which is very promising for the near future if these drugs are going to be implemented in clinical practice. Although there are a number of successful positive trials, if we look at the drugs that have received a label for kidney protection by the regulatory agencies, the FDA and the EMA, there's only actually a few ACE inhibitors, 2 angiotensin receptor blockers, losartan and irbesartan, based on the Renowned IDNT trial, and an SGLT2 inhibitor that has a label for kidney protection and thus can be used and can be reimbursed to treat diabetic kidney disease predominantly. Because there's only one ACE inhibitor, ramipril, based on the RAIN study, that has a label for kidney protection, and then only in Europe and only in patients with an albumin to creatinine ratio more than 3,000 milligram per gram creatinine. So in particular in patients without diabetes and kidney disease, there is a need for new drugs. So what do we know about these SGLT2 inhibitors? Of course, we know that these drugs protect the kidney. And the first trial that demonstrated kidney protection was the EMPA-REC outcome trial in 2016, where when the kidney results were presented. That these findings were actually not expected is clear from the EMPA-REC outcome protocol. Because if we look at the protocol, the kidney endpoint was a secondary endpoint, but was only the last secondary endpoint of a total of about 10 secondary endpoints. So the investigators, when they designed the study in 2012, they had not expected that empagliflozin could protect the kidney, but when they finished the study, they saw a 46% relative risk reduction. These results were then replicated in 2017 in the CANVAS trial and in 2018 in the DECLARE-TIMI trial. These were all cardiovascular outcome trials, and the patients that were included in these trials were patients with relatively preserved kidney function. In 2019, as I already mentioned, the Credence trial was published, which was a dedicated kidney outcome trial in diabetic kidney disease, and that trial also demonstrated that the SGLT2 inhibitor canagliflozin significantly reduced the risk of kidney failure. When we look at the rate of kidney function decline in the Credence trial, we see a typical pattern that we have seen with many SGLT2 inhibitors, actually all SGLT2 inhibitors. During the first week of treatment, there is an acute dip in eGFR of about 5 to 6 mL per minute, which is followed by a complete stabilization of eGFR decline. This acute dip in eGFR indicates that the drug exerts hemodynamic effects. And this acute dip in eGFR is completely reversible after we discontinue the drug, even after years of treatment. And this indicates that SGLT2 inhibitors have hemodynamic effects and reduce intraglomerular pressure, and I'll come back to that in a minute. If we look at the rate of kidney function decline in the placebo arm and in the canagliflozin arm in this study, it's clear that canagliflozin significantly reduced the rate of kidney function decline, which equals 60% relative risk reduction, which is a lot, and actually much more than what is observed with ACE inhibitors or angiotensin receptor blockers. Now, an important question is whether SGLT2 inhibitors can also protect the kidney in people with the lowest eGFR values. In the Credence trial, people had an eGFR between 30 and 90 at screening. And then a couple of weeks later, these patients were randomized. And some of these patients had an eGFR at randomization below 30, in total 171. And a recently published study looked at these 171 patients and found that even in those individuals with the eGFR below 30, canagliflozin significantly reduced the rate of renal function decline, as you can see in this graph. So this suggests that SGLT2 inhibitors can also be used in patients with chronic kidney disease stage 4. And I will come back to that also during the remainder of my presentation. Now, when SGLT2 inhibitors were registered, soon after these drugs were used in clinical practice, the first reports of acute kidney injury were submitted to the FDA and the EMA. And this led to a warning that SGLT2 inhibitors could actually induce acute kidney injury. And patients with diabetic kidney disease are at particular risk of acute kidney injury. So we looked in the Credence trial and wanted to know what the effects are on renal-related adverse events and AKI. Let's first take a look at the renal-related adverse events. If you look at the Kaplan-Meier curve as shown on the left, you'll see that during the first months of treatment, there are indeed more renal-related adverse events with canagliflozin, but then during prolonged treatment, there's significantly fewer renal-related adverse events. And my interpretation is that the investigators who participated in the Credence trial all saw during the first month of treatment the acute dip in eGFR and interpreted this as a renal-related adverse event. But as I already mentioned, this acute dip in eGFR is actually the mechanism of action and the mechanism of protection with SGLT2 inhibitors, because it reflects a reduction in intraglomerular pressure, which is associated with long-term kidney protection. So in overall, we see there are indeed fewer renal-related adverse events. If we look at acute kidney injury, there's no sign whatsoever that canagliflozin in these patients induced acute kidney injury. In fact, the point estimate is in the direction of protection. And if we combine this data with all the other SGLT2 inhibitors and we perform a meta-analysis, SGLT2 inhibitors significantly reduce the risk of acute kidney injury. So although there are clinical practice reports that suggest a risk of acute kidney injury, the clinical trials show the opposite. This doesn't mean that some patients may be at risk for acute kidney injury. In particular, patients who are already using diuretics, in whom circulating volume is reduced due to, for example, reduced oral intake or increased excretion of fluid during an episode of infections and diarrhea, we have to be careful. And therefore, we recommend in such instances to take a drug holiday and stop the SGLT2 inhibitor for a couple of days after the event is resolved. Another issue people ask a lot of questions about is the acute dip in eGFR. What are the clinical implications of the acute dip in eGFR? And we did an analysis in the Credence trial, which you can now read on the website of Kidney International. And we looked at this acute dip in eGFR. In the Credence trial, there were more patients on canagliflozin that experienced a dip in eGFR during the first 3 weeks of more than 10%, 45% with canagliflozin and 21% with placebo. And there were, as expected, fewer patients with an acute eGFR increase with canagliflozin, 27% with canagliflozin on the right and 49% with placebo. Now, what are the consequences of this acute dip in eGFR? Well, if we stratify the population, first the canagliflozin group on the left, according to the acute dip in eGFR in 3 groups, which are approximately equally sized, we see that the eGFR declines over time in these 3 groups. And you can appreciate that during prolonged treatment, the rate of renal function decline in these people with an acute dip in eGFR, the blue line, is the same as those with a modest decrease in eGFR between 0 and 10%, and is the same, actually a little bit less, compared to the people with an acute eGFR increase.
Is that what it's saying? She's back?
Sorry, Dr. Heerspink, I'm going to interrupt. Sorry, there's several people that have their lines unmuted. Can you please mute them? There's a few people that are calling in on phones. Can you please mute those lines? Thank you.
Thank you. Now, if we look at the placebo arm, and we stratify the eGFR dip according to the same definitions, we see a similar pattern as compared to the canagliflozin group. Overall, the eGFR, long-term eGFR trajectories in these 3 groups are similar. But now, if we compare the canagliflozin group with the placebo group, we see that in every subgroup of acute dip in eGFR, the long-term eGFR trajectories are significantly less compared to those patients who receive placebo. So from an efficacy perspective, this acute dip in eGFR, even if it's more than 10%, should not be a reason to discontinue the drug. But of course, we also have to look at the safety of the SGLT2 inhibitors according to the dip in eGFR. And this is a complicated slide, and I will try to guide you through. On the left, you see the patients on canagliflozin, and on the right, you see the placebo group. And now we're looking in the first row at any adverse event, and we have now stratified the population in various groups according to the acute dip in eGFR. An increase, a decrease between 0 to 10%, and then 10 to 20, 20 to 30, and more than 30% decrease. We use the increase in eGFR group as the reference, and then we compare the risk of any adverse events in the other subgroups. And what you appreciate from this slide is that even a decrease in eGFR of up to 30% is not associated with more adverse events. You can see that on the left. Only when the dip in eGFR exceeds 30%, there's a slightly higher risk of any adverse event compared to patients on canagliflozin with no decrease in eGFR. However, the number of patients with more than 30% decrease is small, only 89 patients in this subgroup. If we look at the placebo group, there's no clear pattern according to the acute dip in eGFR. Any serious adverse events were not statistically increased according to the acute dip in eGFR, although the point estimate is shown here is slightly increased compared to the reference group. And renal-related adverse events were more often seen in those with an acute dip in eGFR of more than 30%. So we believe that acute dips in eGFR up to 30% should not be a reason to discontinue the SGLT2 inhibitor. Only when it exceeds 30%, and that's a rare event, then we should reconsider the continuation of the SGLT2 inhibitor. And perhaps it's smart to discontinue the SGLT2 inhibitor. And if you want to re-challenge the patients, I think you can do that to be sure that the change in eGFR that you measured initially is not just a chance finding. Now, guidelines have also started to change based on the results of the Credence trial. The KDIGO guideline came out in October and recommends for the treatment of a diabetic kidney disease as a first step, of course, lifestyle therapy. And then the guideline recommends to start with metformin and SGLT2 inhibition. Metformin can be used down to an eGFR 30, but should not be initiated when the eGFR is below 30 because of a risk of lactic acidosis. SGLT2 inhibitors can also be initiated in patients with eGFR above or equal to 30 mL per minute, but should not be initiated for now if the eGFR is below 30. And then if HbA1c is not controlled with metformin and or an SGLT2 inhibitor, other glucose-lowering agents can be added, and the GLP-1 receptor agonists are preferred agents because of the cardiovascular protective effect. Since the publication of the EMPA-REG trial in 2016, many people started to speculate about the mechanisms for kidney protection with SGLT2 inhibitors. And actually, there are more reviews written than original articles and research articles have been published. But there are many hypotheses postulated, and I have contributed to this, and this is one of the publications I wrote with your colleague David Cherney in Canada, and we hypothesized that the effect for kidney protection are probably due to many different effects. SGLT2 inhibitors reduce the inflammation or could reduce inflammation and fibrosis. They appear to have a positive effect on oxygenation in the kidney. They reduce albuminuria, they reduce blood pressure, they reduce uric acid. But importantly, as I already mentioned, they also reduce intraglomerular pressure through a mechanism which is called tubuloglomerular feedback. Tubuloglomerular feedback is an adaptation of the glomerular tone and serves to stabilize GFR under different settings of renal perfusion and is dependent on the amount of sodium delivery to the macula densa. I won't go in detail, but I can tell you that this high intraglomerular pressure and glomerular hyperfiltration is not only restricted to patients with diabetic kidney disease, but is a common factor in the progression of many kidney diseases. We know, for example, that in patients with hypertensive nephrosclerosis, there is an increase in renal plasma flow due to arterial stiffening and an increase in intraglomerular hypertension. We also know that in patients with obesity-induced chronic kidney disease, renal plasma flow is increased with a resulting increase in filtration fraction and glomerular hyperfiltration, just like in patients with focal segmental glomerulosclerosis. So when we designed the DAPA-CKD trial in 2016, we did not only want to include patients with diabetic kidney disease, but wanted to extend the use of SGLT2 inhibitors to patients without diabetes and chronic kidney disease, because we felt that the mechanism of action could target many different etiologies of chronic kidney disease. What did we know at the time we designed the DAPA-CKD trial about the effects of SGLT2 inhibitors in non-diabetic kidney disease? Well, actually, there was not a lot of data. There was one study, quite a large study, of 400 obese non-diabetic individuals that had shown that canagliflozin reduced body weight compared to placebo and increased urinary glucose excretion in these non-diabetic individuals, suggesting that the SGLT2 inhibitor could retain its pharmacodynamic activity in the non-diabetic setting. We also conducted a study in chronic kidney disease patients without diabetes to look at the short-term effects of dapagliflozin on kidney function. And in this study that we published earlier this year, we measured GFR by iohexol clearance. And we found that dapagliflozin, just like in patients with diabetes, reduced GFR by about 6 to 7 mL per minute compared to placebo, and that this effect was completely reversible after we discontinued dapagliflozin, thus indicating that the effect is a hemodynamic effect and is not a structural worsening of kidney function, and suggests that dapagliflozin in these patients reduced the glomerular hyperfiltration. We also found a reduction in albuminuria in these patients, although that reduction was not statistically significant from placebo. But interestingly, there was a correlation, and you don't see that on the slide, between the reduction in measured GFR and the reduction in albumin to creatinine ratio, so that the higher the reduction in measured GFR, the higher the reduction in albumin to creatinine ratio during dapagliflozin treatment. And this can be expected because if you reduce the pressure in the glomerulus, the pressure on the filter is decreased, and thereby patients start to filter less albumin, and you get a reduction in the albumin concentration in the urine. So this set the stage for the DAPA-CKD trial, which we designed in 2016, as I mentioned, and we enrolled patients, adult patients with chronic kidney disease with a GFR between 25 to 75 and an albumin to creatinine ratio between 200 and 5,000. These patients were all using an ACE inhibitor or angiotensin receptor blocker if tolerated, and were assigned to dapagliflozin 10 mg per day or placebo. The trial was stopped by the recommendation of the Independent Data Monitoring Committee at the end of March, just before the COVID pandemic started. So we had to close out the study in the midst of a worldwide global pandemic, which was not easy, but due to the support and thanks to the support of many investigators who even started to visit their patients at home, we were able to close out the study in an orderly fashion. Now, these are the patient characteristics that were enrolled in DAPA-CKD. They were 62 years on average, 1/3 was female, about half of them were white, 2/3 had a diagnosis of diabetes, GFR was 43, and the albumin to creatinine ratio was very high, median 1,000 mg per gram. And the primary results, which have been published, and you've probably read the publication, are shown in the slide. On the left, you see the effect of dapagliflozin on the primary outcome, a 50% eGFR decline or more, end-stage kidney disease, renal or cardiovascular death, and this endpoint was significantly reduced by dapagliflozin by 39%. And then on the right, you see the secondary kidney-specific endpoint, which excludes CV death, which was also reduced by 44%, and both the primary and this kidney-specific endpoint were statistically significant, as you can see from the very small p-values. We also looked at the effect of dapagliflozin on cardiovascular death or heart failure hospitalization. And as you can see on the left, this endpoint was reduced by 29%. And then I think a notable finding is that dapagliflozin in these patients also reduced all-cause mortality. This reduction in all-cause mortality was predominantly driven by non-cardiovascular death. And then in particular, by fewer deaths due to infections and fewer deaths due to malignancies. And this is interesting, I think, because SGLT2 transporter is expressed on a number of tumors, in particular non-small lung cancer tumors, prostate cancers. They all express SGLT2 inhibitors, transporters to grow, because these tumors need glucose to grow. And that's why, and they use the SGLT2 transporter to grow. And animal studies have actually shown that if you treat those animals with a tumor, tumor growth is delayed or even slowed down or even minimized, so that perhaps even in the future SGLT2 inhibitors could be used for the treatment of some type of cancers. We are now testing that in more detail in my hospital. So when we look at the eGFR decline, you can see that in the DAPA-CKD trial, there was an acute decline in eGFR of about 4 mils per minute compared to placebo, which we had seen with other SGLT2 inhibitors as well. But then during prolonged treatment, there is stabilization of kidney function decline of about 50%. The rate of kidney function decline in the placebo arm was -3.6, and it was -1.7 with dapagliflozin. And the study was actually only on 2.4 years on median. But if we would prolong the follow-up, and these patients in practice won't use these drugs for 2.4 years, but probably a lot longer, you can see that the effects can be much more pronounced if you follow these patients longer. Now, I would like to focus, as I mentioned, on patients without diabetes. So 1/3 of the population did not have diabetes, and 2/3 had type 2 diabetes. If we then look at the investigator-reported cause of kidney disease, 58% had diabetic nephropathy, which indicates that not every patient with type 2 diabetes has diabetic nephropathy. 16% had chronic glomerulonephritis, 60% had hypertensive nephropathy, and the cause of kidney disease was unknown or other in about 10% of these patients. Now, if we focus on these patients with type 2 diabetes, shown now on the right, 86% had diabetic nephropathy. But there were 3% of patients who had a chronic glomerular nephropathy, 7% hypertensive nephropathy, and the cause of kidney disease was unknown in about 3 to 0.4%. Now, what about the effects of dapagliflozin in patients with or without type 2 diabetes? In the top row here, you see the effect of the primary outcome in the top row in the overall population, and then in the rows below in patients with and without type 2 diabetes. And what you'll see and should conclude from this slide is that the effect is in general consistent in patients with and without type 2 diabetes. The point estimates, the hazard ratios, are 0.64 and 0.50, and the p-value for interaction, which is 0.24, indicates that these effects in patients with type 2 and without type 2 diabetes are consistent with the main effect. Thus, we should interpret this as if there's no difference in the effect in patients with and without type 2 diabetes on the primary outcome. If we then look at the secondary outcomes, and this data were published actually yesterday in Answer Diabetes, so you can read it now in the literature, you can also see that these effects were remarkably consistent between patients with and without type 2 diabetes. They were also statistically significant for the renal specific outcome in patients without type 2 diabetes, and at the bottom row you see that the effect on all-cause mortality was even statistically significant in patients without type 2 diabetes. We also have to look at the safety, of course. It's not only about the efficacy, but if we present efficacy data, that should be balanced by the safety. So here you see the proportion of patients who discontinued study medication or experienced a serious adverse event in patients with and without diabetes, and then in the dapagliflozin and placebo group. Well, if we first compare those with and without diabetes, and we look at serious adverse events, you can see that the serious adverse events were more frequently reported in patients with diabetes, which reflects the higher severity of disease in these patients. But if we compare dapagliflozin with placebo in those with or without diabetes, you'll see that the proportion of events are similar between the two treatment groups. There were also adverse events of interest, and in general, the proportion of patients with adverse events of interest, as shown here on the slide, are similar between the dapagliflozin and placebo group. Important to note that there were no diabetic ketoacidosis events with dapagliflozin, both in patients with or without diabetes, and patients without diabetes did not experience major hypoglycemia. So although we are using a diabetic drug, this drug doesn't cause hypoglycemia in patients without diabetes. Now let's take a look at the effect of dapagliflozin by the type of kidney disease. So a similar graph as I just presented, but now stratified by the type of kidney disease being diabetic nephropathy, hypertensive CKD, chronic glomerulonephritis, or cause of kidney disease, other or unknown. And the subgroups become smaller compared to the stratification by type 2 diabetes, but in general, the effects are consistent. The confidence intervals in each subgroup are wider, and the point estimates start to vary a little bit, but the p-values for interaction, which are all not statistically significant, indicate that there is no evidence to suggest that these effects are different in any type of chronic kidney disease. And this applies to the primary outcome as well as to the 3 secondary outcomes. It's interesting to look at the effects of dapagliflozin in patients with IgA nephropathy, because this was the largest subgroup of patients with a chronic glomerulonephritis, and this number of patients enrolled in the DAPA-CKD trial is equal to the number of patients enrolled in dedicated IgA trials, like the testing study or the STOP IgA trial. And these trials were trials on themselves and published in high-impact journals like the New England Journal of Medicine. So basically what we did in DAPA-CKD, being a large trial, we did a dedicated IgA trial. If we then look at the effect of dapagliflozin on the primary outcome in these patients, we see a huge risk reduction of 71%, a hazard ratio of 0.29, with a confidence interval that clearly doesn't cross unity, and thus indicating that dapagliflozin is very potent and very effective in protecting from kidney failure in patients with IgA nephropathy. Now, what about the effects of SGLT2 inhibitors in patients who are using a diuretic? We've done this analysis for 2 reasons, because diuretics are frequently used in patients with chronic kidney disease. And the other reason is that some people believe that SGLT2 inhibitors are just diuretics and would not be effective when you give it already on top of a patient who is already using a diuretic. About 40% of patients use the diuretic, and the effect of dapagliflozin on the kidney endpoint is shown on the left with a hazard ratio of 0.56, which is similar, remarkably similar, to the hazard ratio of 0.55 in patients not using a diuretic. So dapagliflozin can be given on top of a diuretic and you still retain the protective effect. Now, what about the use of dapagliflozin when given on top of a specific diuretic, a mineralocorticoid receptor antagonist? About 5% of patients were using a mineralocorticoid receptor antagonist, mainly, I think, for heart failure. And what you see is that in these patients who are using an MRA, dapagliflozin reduced the risk of the primary endpoint with a hazard ratio of 0.61, which is again similar to the hazard ratio of 0.56 in those not using an MRA. So dapagliflozin can also be given in patients who are already using a mineralocorticoid receptor antagonist. So where does DAPA-CKD fit in the management of patients with chronic kidney disease? I started off with the cardiovascular outcome trials because these were the trials that were done initially with SGLT2 inhibitors and enrolled patients with preserved kidney function, as you can see in this classification of chronic kidney disease grid. They are all done in patients on average with normal albuminuria and eGFR above 60. The Credence trial was then published in patients with diabetic kidney disease with a GFR between 30 to 90, and DAPA-CKD extends these findings to patients with the eGFR down to 25. In fact, we had 623 patients with the eGFR between 25 and 30, and the effects of dapagliflozin were completely consistent in these patients with a GFR between 25 and 30. It reduced the primary and secondary outcomes, and it was safe to use in these patients. So I think it's now fair to state that the SGLT2 inhibitors can be initiated, at least dapagliflozin can be initiated in patients down to an eGFR of 25. We also included patients with a UACR of more than 200, so we extend the albuminuria threshold to the microalbuminuria range. The EMPA-Kidney trial is still ongoing, which is a trial with empagliflozin. And this trial not only enrolls patients with high, but also with very low albuminuria and a low GFR. And hopefully will further extend the indication for SGLT2 inhibitors to those patients as well. It will take 2 years before the EMPA-Kidney trial will be finished. So if we look at dapagliflozin specifically, and we look at the cardiovascular outcome trial with dapagliflozin, the DECLARE trial, that trial demonstrated that dapagliflozin in these patients with preserved kidney function reduced the risk of the kidney endpoint by 46%, a hazard ratio, as you can see on the left, of 0.54. Now, DAPA-CKD had a hazard ratio of 0.56, similar to DECLARE, but now in patients with chronic kidney disease. So dapagliflozin can be used both in patients with early and advanced chronic kidney disease. There's no lower threshold at which you have to stop the SGLT2 inhibitor, because in the DAPA-CKD trial, patients continued the SGLT2 inhibitor until they reached dialysis. What about heart failure? I already presented you the results of the heart failure endpoint shown on the left. And there's also a heart failure trial done with dapagliflozin, and that trial demonstrated that in patients with a history of heart failure and reduced ejection fraction, dapagliflozin reduced the risk of cardiovascular death or heart failure hospitalization by 26%. So similar effect sizes, both in patients with chronic kidney disease as well as in heart failure for the same endpoint. So DAPA-CKD, CKD clearly stands for chronic kidney disease, but we can extend the abbreviation to cardiovascular kidney and diabetes, because dapagliflozin is a protective, organ protective drug in patients with diabetes, in patients with chronic kidney disease, as well as in patients with heart failure, and the proportion of patients with the different conditions are shown here in orange. And now the effect of dapagliflozin on the kidney composite outcome or on the heart failure, cardiovascular death outcome in these three populations are similar regardless of the phenotype of the patient. So I've shown you that in patients with chronic kidney disease with and without type 2 diabetes, dapagliflozin compared to placebo reduced the risk of kidney failure, hospitalization for heart failure, and prolonged survival. And these benefits were consistent in patients with and without type 2 diabetes with different CKD etiologies, and were not different in those who were using or not using a diuretic. So dapagliflozin is protective in patients with early and advanced chronic kidney disease. I thank you for your attention, and I think we'll have time left for some questions and answers. Thank you.
Thank you very much, Dr. Heerspink. Let me just move my computer over here. Yes, we do have some time for some questions. So I think it's probably easier for people just to speak up rather than trying to look through this hand raising and stuff. But I do want to ask a couple. I have a question actually to start things off. In this DAPA-CKD, there was very little hypoglycemia, which was obviously reassuring. But in the patients with diabetes, so they were on insulin or some oral agents, was there anything in the protocol that they were to, reduce something, like reduce the insulin dose or reduce the metformin or something before they entered the trial, or was this just left to the investigators?
This was left to the investigators. And I don't think there were many people who changed the insulin dose or the metformin dose. And we know that in patients with chronic kidney disease, the effect of SGLT2 inhibitors on HbA1c is very modest. We saw in the Queen's trial, and actually also in the DAPA-CKD trial, a 0.25 to 0.35 reduction in HbA1c, and that may be the explanation why there's so few hypoglycemia seen in this study. And actually in the non-diabetic patients, we saw in the DIAMOND study, which is a relatively small study, and we have to do the analysis in DAPA-CKD, that there was no change in HbA1c in these non-diabetic individuals. And that explains probably why there's also no hypoglycemia.
So as nephrologists tinkering around with these medicines, you don't think we need to adjust their diabetes pills if we're going to start them on these?
No, no. And we have to be careful, right? Because if we stop reduce the insulin dose, we may actually increase the risk of diabetic ketoacidosis events. And therefore, I, I, I think we can add them, in particular because of the small effect on HbA1c.
Great. Other questions? People, please just speak up. I think it'd be the easiest way.
Yeah, there's a question in the chat.
Yeah, but before we go there, on the issue of that DKA, there was no euglycemic DKA at all in DAPA-CKD. I know in Credence they did have something like sick day rules. Was there something similar in the protocol for DAPA-CKD?
No, we did not specify anything in the protocol. We had sick day rules in Credence, but remember that DAPA-CKD was started after Credence, and I think that people became more aware and they started to learn more about DKA and how to handle the potential DKA risk. And that's maybe have been our advantage. I don't think that dapagliflozin has a specific better profile for DKA than canagliflozin. In my interpretation is that the SGLT2 inhibitors have shown a class effect, both with respect to efficacy as well as safety. And thus you could argue that you can use any SGLT2 inhibitor in clinical practice. Well, I don't follow that argument, because from a clinical perspective, I would always use an SGLT2 inhibitor that has proven efficacy and safety in a population. And thus, for patients with diabetic kidney disease, I would always choose between canagliflozin or dapagliflozin. And for patients without diabetes and kidney disease, I would always select dapagliflozin, because that's the only SGLT2 inhibitor that has been shown to be protective and safe. And we don't have that evidence for other SGLT2 inhibitors.
Can I follow up on that idea of the sick day rules? Did you keep track of which patients took drug holidays, or whether that was actually done?
Yeah, that's done in the study by protocol. So at every study visit, we ask the patient whether they continued the medication. We have the pill count data. We ask whether they had initiated the sick day rule. And as far as patients remember, they have reported that. We haven't analyzed that data in particular. We are focusing on a number of other analyses at the moment, but we could analyze it.
And another question, and one of my colleagues also had it, was did you keep track of whether diuretic doses were changed after initiation of?
Yeah, we have that information. We know at every visit what kind of concomitant medications patients were using. And it may be that in some patients the diuretic dose was reduced. I would do that as well, in particular in patients with a reduced circulating or dynamic circulating volumes, and you see that there may be hypotension occurring, particularly in elderly patients. I would recommend to down titrate the dose of the diuretic and then initiate an SGLT2 inhibitor, because I feel that SGLT2 inhibitors are much more protective for kidney disease than a traditional diuretic.
There was also another question in the chat, Dr. Heerspink, about the use in PKD patients. I think that's what Zimmerman's asking.
Yeah, many people ask that question, and we didn't enroll patients with polycystic kidney disease because we felt that the mechanism of disease progression with cyst growth isn't targeted by SGLT2 inhibitors, and therefore we were not confident at the time we designed the study that this drug would be beneficial for these patients. In addition, at the time we designed the study, there was 2 experimental studies that actually suggested that SGLT2 inhibitors may accelerate cyst growth. So there was another reason why we didn't want to enroll these patients. There are now some experimental data that suggests that perhaps SGLT2 inhibitors could be protective in these patients. And there's also another interesting study that suggests that SGLT2 inhibitors may counterintuitively reduce the urination and this volume excretion when you start tolvaptan therapy. And thus, that's an interesting hypothesis which could be tested in a future study. But this were the reason why we didn't enroll patients with ADPKD.
Dr. Heerspink, you showed the Credence patients that had GFR below 30. Do you have any data on DAPA-CKD patients with GFR below 25?
Below 25? Yeah, well, there were some of them. remember at screening, they needed to have a GFR between 25 and 75. And then 2 weeks later, they were randomized into the study. And when we looked at the randomization eGFR values, there were about 100 who had a GFR below 25. And we haven't analyzed that very small subgroup specifically. I would think that the drug is completely safe in these patients as well. I have no concern that the drug wouldn't be, but we can definitely look at it. We are actually finishing a manuscript on the efficacy and safety in patients with a GFR between 25 and 30 at screening, but we can add an additional analysis for those patients with a GFR below 25 at randomization to look at those as well.
Thank you.
I'm interested in the eGFR data as well. So you showed those differences over time, which are interesting. Were those final measurements for every patient in the study? Did they discontinue the drug to take the final measurement, or were those on-drug measurements?
Yeah, these analyses are always done on treatment.
Okay.
So instead of the intention to treat analysis, we take only the patient who continue their SGLT2 inhibitor, because during follow-up, if a patient stops the drug, the initial dip in eGFR reverses. And thus, if you would take those measurements into account, you would actually overestimate the efficacy on slope for dapagliflozin, and that would not give the right picture. So that's why we do the on-treatment approach for the eGFR slope analysis.
From a practical aspect on the dose of these drugs, the empagliflozin, I think in EMPA-KIDNEY, they are going at the lower dose of 10 milligram, and canagliflozin, it's again 100 milligrams.
Yeah.
Whereas DAPA, I think, comes in 5 and 10, and you chose to have 10. Do you think there's anything special with the dose, or we should just use the dose that was used in the trials?
Yeah, it's interesting, isn't it? These dose finding studies were done based on urinary glucose excretion. And now we know that these effects that we see on clinical endpoints are to a large extent independent of glucose glycemic control. So what is the optimal dose? If you look at the dose finding studies, the 10 milligram of DAPA falls between the 10 and 25 for empagliflozin, and is actually close to the 100 with canagliflozin. We allowed investigators during the trial to down titrate the dapagliflozin to 5 milligrams per day in case of adverse effects. And the reason was actually that we knew that the effects on the clinical endpoints are expected to be similar. If you look at albuminuria, for example, there's no big difference between 5 and 10. And this was mostly for patients that would complain about side effects and wanted to stop the drug. We felt, well, we give them the option to down titrate to 5 so that they could stay on medication, which is better than nothing. And therefore, we would have a better treatment effect than giving them nothing. And hope that there will be fewer side effects. But if you carefully look at all these dose-finding studies, perhaps we should have done a dose-finding study for albuminuria, which is a better marker of kidney protection than urinary glucose excretion. So when we designed the DAPA-CKD trial and we went to the FDA, and the FDA asked us, why did you use 10? Our stupid answer was, it's only based on, these were the dose-finding studies. And then the FDA said, but why not 20, 50, or 100? And we said, we could do it. And the FDA said, well, do whatever you want. and then we decided to go for 10. And were successful, you could say. But maybe we're even more successful if we would have used 20. Nobody will know.
Just a follow-up to that, did you analyze the data based on those the patients that had to drop down to 5 over time?
And there were very few that dropped down to 5. Only 43 patients. So that's too small to do an analysis for. Yeah. Which speaks to the safety of the drug, right? Because there were very few patients who asked for a lower dose. Yeah.
Just have a question about timelines of benefit. You know, when you're in the clinic now, I'm actually looking at who shouldn't be on the drug, as opposed to who should be on the drug. Mm-hmm. But for our folks who are very advanced in age or multiply comorbid, when you're looking at kind of life expectancy, is there sort of a cutoff where it's unlikely that they're actually going to benefit from the addition of another medication?
Yeah, good question. If you look at the Kaplan-Meier curve, some people look at the Kaplan-Meier curve for the primary endpoint, and then they say, well, it takes a year before you see the benefit. because I can see that the curves start to diverge after a year or after 6 months. So it takes 6 months. I disagree with that, because we started off with a cohort of patients with a mean GFR of 43, and it just takes time for the placebo group to reach the endpoint. This is different from a heart failure trial where patients can have directly an endpoint as soon as they are in the trial, because they can be admitted to the hospital for a heart failure event. Whereas in a kidney trial, you first have to progress until you reach dialysis, and that takes time. So we have to rely on surrogates for protection, and our surrogates are eGFR slope and reduction in intraglomerular pressure and albuminuria. Well, if you look at the effect on eGFR and the acute effect on eGFR, that's present after 24 hours. There are studies that have measured the next day GFR, and you can see that the GFR has fallen by 4 mL per minute after 24 hours. If you look at albuminuria, we did a study after 4 days, we saw a reduction in albuminuria. So I think that the effects are directly present, both for the heart and for the kidney, but it only takes time before these effects translate into endpoints, because patients have to progress and the manifestation of the clinical endpoint takes longer. So even in elderly patients, where analyses from EMPA-REG, CANVAS, Credence have shown that these drugs are safe and effective in people older than 75, I would recommend to use them. So to your question, who shouldn't use them? Perhaps patients with a history of diabetic ketoacidosis, perhaps patients in whom you know that the circulating volume is dynamic and can suddenly change, perhaps patients with a history of urinary tract infections. But in general, there are not many other patients that should not receive these agents.
Following up on that, sometimes we see a lot of natriuresis in someone who has uncontrolled diabetes with, severe hyperglycemia, like that, hemoglobin A1C at 15% or whatever. Is that sort of, should we get their sugars a little bit under control before we put them on an SGLT2 inhibitor?
I don't know, actually, because these patients may also benefit a lot in terms of glycemic control. We know that the efficacy is enhanced in people with high HbA1c values. So the question to me is this patient treatment adherent, particularly if the patient is already using a lot of drugs? Is the patient using the medication? And perhaps first focus on that and then initiate the SGLT2 inhibitor.
I have a question about the AKI data. One of the very interesting things that I think have come out of both the prospective trials as well as some of the observational studies that have come out more recently is a significant reduction in the risk of AKI. And two questions. One is, what do you think the mechanism is? And number two, do you think that SGLT2 inhibitors are necessarily sick day medications?
The mechanism, in my view, is that these drugs stop the reabsorption of sodium in the proximal tubule. And that's the oxygen requiring process. And therefore, because in these patients with diabetes who reabsorb a lot of sodium and glucose, there's a high oxygen demand and there's hypoxia in the kidney, particularly in the proximal tubule. And that leads in many animal studies, but also in patients, to an acceleration of kidney function decline. So if you block that reabsorption in the proximal tubule, you decrease the oxygen and energy demands and thereby relieve the hypoxia in the proximal tubule. And if you look at markers of proximal tubular damage like KIM1, in all the studies I've measured KIM1 with SGLT2 inhibitors, there is a reduction in KIM1 levels. So in my view, that's the hypothesis, and that's also nicely written by one of your colleagues in Canada. I'm blocking on the name. Anyway, he called it the beta blocker for the kidney, which is nice idea. And thus, could SGLT2 inhibitors actually be used for the treatment of acute kidney injury? That's an interesting hypothesis. I believe there's one trial ongoing in the United States that tests that hypothesis, and it could well be, yes.
So should we hold them when, should they be a sick day medication that we hold when somebody is ill?
I think, if a patient goes for surgery with diagnostic agents, I would hold the medication. I would hold the medication if it's very hot outside. The patient is already using a diuretic, an ACE inhibitor, and an SGLT2 inhibitor. I would consider to hold the medication for a couple of days, because as I said in my presentation, I don't believe that these reports of acute kidney injury submitted to the FDA were wrong. I think they were true, but there were certain circumstances that could elicit the acute kidney injury, not because of the SGLT2 inhibitor, but because of other extraneous events that when these patients are exposed to these events, they increase the risk of acute kidney injury.
Thank you.
If I could ask the last, sorry, go ahead.
I was just going to ask in terms of other times not to start active foot ulcers. Not a history of them, but if they actually have one now, and then if they develop one, I think at the moment they're continued on the medication.
Yeah, and I think that's fine. There was a perceived, there is and there has been an increased risk of amputations with canagliflozin, and it's still unclear whether that is just a chance finding or whether that's a real event with canagliflozin. The FDA has downgraded their assessment of amputations with canagliflozin, I believe, because it wasn't seen in the Credence trial. It isn't seen with other SGLT2 inhibitors. And when this came out, people felt that this maybe because of more infections due to foot ulcers, etc. I think we didn't see more amputations in the DAPA-CKD trial, not in the DAPA-HF, not in the declared TIMI, and all the other SGLT2 trials. So I think you can continue.
So if I could squeeze in another last question. Patients with SLE and vasculitis were excluded in DAPA-CKD. And I can understand if someone has an active disease process, that would make sense. But what if someone has, quiescent lupus or, the vasculitis is no longer active, but they still have CKD, right? Would it be appropriate? To me, it looks like, why not?
Yeah, I think so too. This is exactly the reason why we excluded this patient, because we were concerned that during follow-up, suddenly there could be a flare and there could be an active process, and then these patients accelerate, and that would damage a fair comparison between the dapagliflozin and placebo group. But if it's quiet and these patients are stable, but still have chronic kidney disease, and you still want to slow the progression, I think it's worth considering.
No other questions? Well, I'd like to again thank Dr. Heerspink for coming and speaking this morning. It was an excellent talk, answered, I think, a lot of questions we've had about using these agents, and I think all of us are getting more comfortable prescribing them. I think we were certainly in our practice sort of deferring to the diabetes specialist, but I think we're all now getting more comfortable, and I think your presentation has certainly helped us get a little more comfortable using these medications. So again, thank you on behalf of the division, and best of the holidays.
Wish you also Merry Christmas and all the best.
Thank you.
Thank you.
Bye-bye.